Hello, everyone. My name is Caitlin Bathis-Lasky, and I'm the Manager of Patient Programs, Research, and Advocacy at Lymphoma Canada. I'm pleased to welcome you all today to our educational webinar hosted by Lymphoma Canada at our national conference on marginal zone lymphomas. We appreciate those of you able to join us live today to learn more about the disease-specific biology of marginal zone lymphomas. We will examine the current Canadian treatment options available, and we'll also highlight some treatments coming to Canada related to some of the research and results behind new therapies. Before I go ahead and introduce today's speaker, I would like to provide a bit of guidance about the Zoom software. This virtual software does not allow for you to share your video or your microphone. If you do have a question, please save it for the non-Hodgkin lymphoma Q&A session following this breakout presentation. You can then ask your questions to the presenters live. I would now like to introduce and welcome our speaker today, Dr. Kai Lueka. Dr. Kai Lueka is a hematologist at the BC Cancer Surrey, focused on diagnosis, treatment, and management of patients with hematological malignancies. He has additional training in bone marrow transplantation, as well as a basic research background with his postdoc fellowship at the Terry Fox Laboratory in Vancouver. He is an assistant professor at the University of British Columbia in the Faculty of Medicine and is engaged in teaching of students, residents, and fellows. He participates in several clinical trials, quality improvement projects, and educational projects for patients, students, and medical professionals. We thank you very much for joining us today to speak on this lymphoma subtype. I would now like to turn over the presentation to you. Thank you very much.
Thank you, Caitlin, for these kind words, and welcome to the session about marginal zone lymphomas. I will provide you a brief overview of my talk today. I want to talk to you in general about the disease heterogeneity of marginal zone lymphomas. We'll talk about staging and prognostic factors that might influence the treatment. Then we will spend some time on treatment and treatment of specific subtypes, talk about relapse disease and some emerging treatments that might become available in the future. I will try to stay away from discussing treatments that are not available here in Canada. Canada is, again, a little bit different when it comes to the availability of drugs and treatment options, given the funding situation, which might differ even between provinces. If you go on the World Wide Web and research treatments for lymphoma, you find way more drugs, which are, for example, available in the United States. Again, due to the different funding structures, these likely will not apply to us here in Canada. So first of all, lymphoma can be a very confusing disease because there are many hundreds of different subtypes of lymphoma. And I think it's very important to start off with bringing a little bit of order in the lymphoma world. So lymphoma is a big umbrella term, and lots of people always approach me and ask me, well, do I have a non-Hodgkin lymphoma or a Hodgkin lymphoma? As a matter of fact, Hodgkin lymphoma is actually quite rare. Only 10% of lymphomas are actually Hodgkin lymphomas. The vast majority, about 90%, are non-Hodgkin lymphomas. And of these non-Hodgkin lymphomas, about 90% again are B-cell lymphomas as opposed to T-cell lymphomas. We're not going to talk about T-cell lymphoma today. To again bring a little bit of more order into the non-Hodgkin lymphoma world, it is easy to distinguish two distinct subgroups. One would be the aggressive lymphomas, with the most common one being the diffuse large B-cell lymphoma, and others. We're going to talk about indolent lymphomas, which makes up the other half. And the most common subtype of follicular lymphoma is follicular lymphoma. And that's what most of the literature and results are based off that I'm going to discuss today. Marginal zone lymphoma is the second most common indolent lymphoma, but unfortunately, lots of clinical trials focus on follicular lymphoma, and there are very limited trials that focus on this specific subtype. So the next question is, what is lymphoma? So lymphoma is a blood cancer and therefore behaves and gets treated completely different when compared to, let's say, a solid tumor. So we have to talk about the origin of lymphoma, which can start off in the bone marrow. This is where all blood is being produced, including the red cells, the platelets, and the white blood cells. The white blood cells harbor the B cells. So these B cells are being made inside the bone marrow. And once they grow up, they leave the bone marrow and then further mature in the lymph nodes. And the maturation of these lymphocytes, these B lymphocytes, happens at different stations within the lymph node. And at any maturation stage or process, something can go wrong with these lymphocytes and they become cancerous or can become cancerous. Depending on their stage of maturation, you get different types of lymphoma. So you see here that in the bone marrow, these cells mature and then further undergo additional changes inside the lymph nodes. So in the germinal center, if something happens here, you get, for example, diffuse large B-cell lymphoma. If something happens in the so-called marginal zone of the lymph node, here you get a marginal zone lymphoma. I already pointed out in the beginning that there is not the marginal zone lymphoma, but that this is a group of different subtypes of marginal zones. So we distinguish three main subtypes. One would be the nodal marginal zone lymphoma, which leads to a swelling of the lymph nodes, hence the name. Then there is the splenic marginal zone lymphoma, which affects mainly the spleen, leads to a big spleen, and can sometimes also affect the bone marrow at the same time. And then there is the big group of extranodal marginal zone lymphoma, meaning that the lymph nodes are not primarily involved. They can be involved, but usually are not. And this then can happen to any organ of your body. It can happen in the skin, in the orbit or ocular area, thyroid, and also the intestines. And in particular, that's a subtype that is affecting the stomach or a gastric lymphoma. These extranodal marginal zone lymphomas also harbor the subgroup of MALT lymphoma, which relates to a mucosa-associated lymphoid tissue lymphoma, which is just another wording for lining of tissue with lymphoid tissue to protect us and keep us healthy. The general symptoms of lymphoma are the painless and usually progressive swelling of either lymph nodes or tumor deposits. Some patients do develop constitutional or B symptoms, which include unexplained fevers over 38 degrees Celsius, unintentional weight loss, or drenching night sweats. Marginal zone lymphoma is not known to exhibit these symptoms on a high frequency. About 15% of patients only report these symptoms. Some patients are plagued by excessive fatigue. Some patients get GI symptoms because of their enlarged spleen or involvement of the lymph nodes in the abdominal cavity. Further, there might be some more specific symptoms depending on the location of the lymphadenopathy. For example, if a patient with lung involvement of the lymphoma comes up, he or she might represent with respiratory symptoms, a cough, shortness of breath, wheezing, and so on. Gastric lymphoma can cause discomfort, early satiety, reflux symptoms, and so on. A large spleen can lead to left upper quadrant discomfort in the abdomen, again, early satiety, and bloating. Some of the marginal zone lymphomas are also associated with autoimmune diseases, for example, thyroiditis and systemic lupus erythematosus. What's also interesting is that other subtypes of lymphoma are linked to chronic infections. The poster child of this subtype is the gastric mold lymphoma, which is linked to the infection with Helicobacter pylori. Same thing is true for splenic marginal zone lymphoma, which is linked to chronic hepatitis C infections. The other listed lymphomas here are, at least in the literature, described to be related to infections, but the response to antibiotic therapy in these instances is rather poor, as opposed to treatment in the setting of gastric lymphoma and splenic lymphoma. Once we talk about lymphoma, the important part is to obtain a biopsy in order to confirm the diagnosis and to determine the subtype of lymphoma. And I would like to stress that an excisional or surgical biopsy is considered the gold standard and should always be the goal. Core biopsies sometimes can be sufficient. A fine needle aspirate or FNA is definitely inappropriate in this setting of working up a lymphoma. Biopsies can sometimes be tricky. For example, gastric lymphomas often do not involve the most superficial lining of the stomach, and it is sometimes difficult to obtain deeper biopsies of the stomach. Staging also includes a biopsy of the bone marrow to determine the stage, which will then complete it with imaging studies, usually involving a CT scan of the neck, chest, abdomen, and pelvis. A PET scan has limited value because marginal zone lymphoma usually does not light up in these scans. Different laboratory studies should also be undertaken, including serology for hepatitis and HIV. This is a biopsy of a spleen involved by lymphoma. In the background, you can see the pinkish material with these little blue nodules, which represents healthy spleen tissue, which is then infiltrated by these larger blobs of tumors representing the lymphoma. The bone marrow biopsy, represented here, reveals the bone in pink and a background of fat and other blood-producing cells. And then again, you can appreciate the infiltrate of these dark blue monomorphic. In some cancers, cytogenetics play an important role. And we undertake cytogenetics in form of detailed analysis of certain genes, as well as a so-called karyotype. Unfortunately, there are no pathognomic abnormalities associated with marginal zone lymphoma, but rather a hodgepodge of different alterations. The most important part are imaging studies. I here show you a CT scan of a patient who presents with an enlarged spleen. The spleen should be usually a quarter of the size. The CT scan is then reviewed and the disease distribution is evaluated. This then determines the stage of the disease. If it is limited to one single lymph node station, that's stage 1. If it is everywhere in the body, it's stage 4. Additional blood tests should be undertaken as well. As we pointed out earlier, we look for low red blood cell count or hemoglobin, which can lead to fatigue. Low platelet count can lead to bruising or bleeding, and low white cell count can lead to infection risks. Also, we would have to ensure that there are no issues with the liver or kidney, which can sometimes be due to the lymphoma itself and would require adjustment of treatment. And we already talked about chronic infections, hepatitis and HIV. In particular with hepatitis, there is a risk of exacerbation of chronic hepatitis to active hepatitis with the use of immunosuppressive chemotherapy. When it comes to the prognosis, there is currently no standard system to assess the outcome of patients with marginal zone lymphoma. We usually extrapolate the response to treatment from the so-called FLIPI score, which was developed for follicular lymphoma and has certain parameters, including age, the extent of the disease, as well as two laboratory parameters, the LDH and hemoglobin less than 120. However, marginal zone lymphoma is usually considered to have a good prognosis. In general, the 5-year survival rate of nodal marginal zone lymphoma is about 55 to 80%, which is, compared to other cancers, quite good. We even think that limited stage disease can potentially be cured. The biggest indicator of prognosis is if a patient does require treatment, how long is the first remission? This will give us a good indicator of the aggressiveness of the disease. The issue with treatment is that despite marginal zone lymphoma being so common, all the studies, as I said earlier, focus on follicular lymphoma, and the subgroup of marginal zone lymphoma is often underrepresented in these clinical trials. Nonetheless, we know that treatments for follicular lymphoma usually also work for marginal zone lymphoma. I will discuss a couple of drugs and drug regimens which are Health Canada approved. And again, I would like to point out that funding and availability might be different from province to province and even center to center. So please speak to your care provider, to your hematologist or oncologist about these treatment options, and I will only discuss these in general ways. Quite often, because of the indolent or slow-growing nature of the disease, we do not initiate treatment upon the diagnosis itself. Several trials have shown that patients who go on this watch and wait approach do just as fine as patients who go into treatment right away. However, it also shows that some patients do not require treatment even in their lifetime, as this is often a disease of older people, and therefore patients die of natural causes or old age. On the other hand, limited stage disease can sometimes be cured with, for example, radiation, and therefore, even in asymptomatic patients, treatment can be indicated in these instances. I would like to focus on a couple of subgroups of marginal zone lymphoma. So again, for nodal marginal zone lymphoma involving the lymph nodes mainly, a watch and wait approach in asymptomatic patients is absolutely reasonable. Radiation can be entertained in cases with low tumor burden or limited stage disease. And we'll talk about the use of single agent rituximab or chemoimmunotherapy in advanced stage disease. Surgical removal is sometimes useful in extranodal marginal zone lymphoma. I had several patients with cutaneous or skin involvement where the removal of the little lump led to a cure, and these patients did just fine. Same thing is true with radiation. The complete response rate is close to 100%, and as pointed out here, the 10-year survival rate is about 87%. Only again in symptomatic patients would we discuss the use of chemoimmunotherapy. Splenic marginal zone lymphoma, as I said earlier, is associated with hepatitis C, and this needs to be ruled out, as the treatment of hepatitis C can lead to a regression of the marginal zone lymphoma. In, again, asymptomatic patients, watch and wait is appropriate. The first-line therapy is still thought to be a splenectomy, as the enlarged spleen can often lead to the major symptoms like early satiety, discomfort, bloating, and also in lowering the blood counts. as there is sequestration of platelets, red cells, and white blood cells. These lymphomas also respond very nicely to single-agent rituximab, and rarely do we use chemoimmunotherapy or more aggressive treatments. Treatment of gastric mold lymphoma usually involves eradication of the underlying infection with Helicobacter pylori. If this infection is present and then successfully treated, about 80% of patients achieve a complete remission and likely cure. We know about risk factors which predict resistance to H. pylori, resistance which are associated with a translocation 114 as well as translocation 1118. In these instances, we would proceed with radiation therapy, again in curative intent. Chemotherapy is rarely used in these patients' populations. When we talk about radiation, this is usually done by the radiation oncologist, and he or she will determine then the dose, frequency, and duration of treatment. This depends on the location and the extent of the disease and will be discussed with each specialist. Chemotherapy, on the other hand, is discussed with your oncologist, and there are, as I said earlier, multiple drugs or drug combinations available. The choice of drug depends on several factors. In particular, the patient, him or herself, the comorbidities of the patient, funding, the side effect profile, previous treatment, if we're talking about the relapse setting, and so on. So I would like to talk about a couple of drugs which are Health Canada approved and frequently used in the setting of marginal zone lymphoma treatment. Rituximab is been around since the 1970s and is a so-called monoclonal antibody. It is able to bind to a surface protein called CD20, which is present on all B cells, including lymphomatous B cells. Rituximab then flags these cells, and other immune system cells are able to activate apoptosis, which is a so-called cell death. It is usually given intravenously or subcutaneously as a single agent, just by itself, or in combination with other drugs. It's usually quite well tolerated. Infusion reactions are frequent, but they usually are limited to the first infusion only. Immunosuppression and low white cell count are the most common side effects. A hepatitis reactivation can occur, and that's why it's important to exclude underlying chronic hepatitis. Rituximab was tested in marginal zone lymphoma in the so-called RESORT trial. In this trial, the drug was given initially for 4 doses weekly, and then patients were either observed and retreated once the disease came back, or they were continued on so-called maintenance treatment every 13 weeks. And interestingly, there was no difference in these two treatment arms, meaning if we give a single 4-week course of the drug in yellow, the results are similar or basically the same when compared to the maintenance treatment. It took about 4 years for the patients to require additional treatment in both arms. Therefore, maintenance treatment has not been considered a standard of care, but the single 4-weekly regimen. Other chemotherapeutic agents are not standardized either. Usually a combination of rituximab and classical chemotherapy drugs are given. Some partners include chlorambucil, bendamustine, cyclophosphamide, and so on. The results are often extrapolated from clinical trials that mainly involve follicular lymphoma. One of the biggest trials that was geared towards marginal zone lymphoma, and in particular mild lymphoma, was reported in 2017, and the use of chlorambucil and rituximab was investigated. This was a phase 3 trial involving 450 patients, which had no previous treatment. The response rate in this setting was almost 95%, and almost 80% of the patients achieved a complete remission, meaning they could no longer detect the disease. The median progression-free survival was not reached, and this is at a point 8.3 years after the treatment was initiated. At the 5-year mark, 90% of the patients were alive and well without disease recurrence. I would like to emphasize that this only involves mild lymphoma, so we're not talking about nodal marginal zone lymphoma or splenic marginal zone lymphoma at this point. Another treatment combination is the use of cyclophosphamide, vincristine, and prednisone with rituximab, or CVPR. A study including marginal zone lymphomas included 40 patients. Response rates were again very high, almost 90%, with the majority of them achieving a complete remission. At the 3-year mark, 60% of patients were well without disease recurrence. The most commonly used drug combination nowadays is bendamustine in conjunction with rituximab. It is given intravenously on 2 consecutive days every 4 weeks for up to 6 cycles. It's usually quite well tolerated. There is no hair loss associated with this regimen. The main side effects include infections and low white cell count, as well as skin rashes. Some patients report neuropathy, which is usually reversible. Data about this drug combination stems from 2 big trials, the STILL trial as well as the BRIGHT study. I put up the graphs from the BRIGHT study, which compared the combination of bendamustine and rituximab to a rather aggressive chemotherapy regimen called R-CHOP. This trial included 46 patients with marginal zone lymphoma. In this subgroup of patients, the response rate was close to 100%, 97%. And the progression-free survival was 57.2 months, so over 5 years. And the important message is that patients can be spared the aggressive R-CHOP chemotherapy and do just as good with the much milder and more tolerable combination of bendamustine and rituximab. And this has led to this combination to be used preferably in low-grade or indolent lymphomas in general. I want to come back to the mild lymphomas. There has been a phase 2 trial also looking in particular in mild lymphomas using bendamustine and rituximab. Of note is that this also included a couple of patients that have been treated previously, for example, gastric lymphomas who underwent H. pylori eradication unsuccessfully. Again, 60 patients were involved in this trial. The response rate was 100%, and almost all of them had a complete remission. The event-free survival at 7 years was close to 90%. Often I get asked about maintenance treatment, and as we discussed in the very first rituximab slides, there is limited role for maintenance treatment rituximab. Some centers still have the availability and funding for this. It is likely associated with an improvement in progression-free survival. Multiple studies in follicular lymphoma as well as marginal zone lymphoma showed no benefit of overall survival, meaning we can keep the disease at bay for a little bit longer, but there is no difference in survival. We consider marginal zone lymphoma to be incurable, Relapses can happen at any time, but usually this happens years or sometimes decades after the initial treatment. If patients relapse within 24 months of the initial treatment, this is usually associated with a poorer prognosis. Once again, there is no gold standard in terms of treatment for recurrent disease. If treatment is required after a long remission, a retreatment with the same regimen can be entertained. And again, as long as the patient is asymptomatic, there's no need to rush into treatment again. The general treatment options are similar compared to the initial treatments and include mainly radiation and chemoimmunotherapy. However, in Canada, we also have availability of a couple of additional drugs, one of them being obinutuzumab, which is also a monoclonal antibody targeting CD20. This drug is effective even after the use of rituximab, as it has a slightly different mechanism of action. However, it is also associated with a higher risk of side effects, meaning it is so effective that it can lead to tumor lysis syndrome, which can damage kidneys, liver, and so on with the initial use. It is given usually in combination with other drugs like bendamustine or other chemotherapeutic agents. Other drugs that are available are also non-chemotherapy drugs. One of them is ibrutinib. Ibrutinib has been Health Canada approved in the relapsed setting. This is a Bruton's tyrosine kinase inhibitor. BTK is part of the B-cell receptor pathway. At the cell surface of these malignant cells, you have an activation of this receptor, which leads downstream to cell growth. And with the use of ibrutinib, we can disrupt this pathway and inhibit further proliferation and worsening of this disease. The drug has previously been extensively studied in the setting of CLL and SLL and is used broadly there. It is given orally and ongoing until the disease comes back or the patient encounters side effects. There's currently, there is a phase 2 trial available with marginal zone lymphoma patients included. The average patient had 2 previous lines of therapy in this trial. I'll show you the outcome on this slide. Again, the drug is quite effective. The median progression-free survival was 14.2 months. So again, these were previously treated patients, and the disease stayed away for about a year and a bit. Does not mean that at that point the patient had to be retreated or a treatment had to be switched. Survival is the graph down here, and you can see that even though the disease comes back, patients live on, are able to go on other lines of treatment. The most experienced side effects include infections, fatigue, and neutropenia. Sometimes bleeding or bruising is experienced, and some patients also have atrial fibrillation, irregular heartbeat. Upcoming treatments that are not currently available in Canada are, for example, venetoclax, which is a BCL2 inhibitor. BCL2 is a protein that prevents cell death, and there are certain cancers that have an increased amount of BCL2 in their cells. Venetoclax is again taken by mouth, and it is currently being investigated as a single agent or in the combination with, for example, rituximab. This drug is also highly effective right away and can lead to tumor lysis. Because of this, sometimes patients need to be admitted to hospital to start this type of treatment. Another drug class are so-called PI3 kinase inhibitors. The PI3 kinase is also involved in the B cell receptor pathway, so that's why I show you this picture again. The first drug in this class was called idelalisib, but since then there have been newer versions of this drug with higher effectiveness and different side effect profile that are currently being trialed in marginal zone lymphoma. There is a small study which has been reported as a phase 2 data with a response rate of about 57% and a progression-free survival of just under a year. The overall survival, or the median overall survival, was about almost 2 years in this trial. However, these people were again heavily pre-treatment and had multiple other lines of treatment prior. Another drug is called lenalidomide or Revlimid, which is an immunomodulatory drug. It is currently used extensively in the treatment of multiple myeloma. The biggest trial is the so-called Augment trial, which compared Revlimid to the use of Revlimid plus rituximab, R-square. Between these two regimens, there was no difference when it came to progression-free survival or overall survival. However, a subsequent trial, the Magnify trial, continued treatment in patients who did have a good response to the initial treatment. And in this trial, the overall response rate was around 65%, with a progression-free survival over 3 years. My colleagues from radiation oncology or nuclear medicine also are involved in the treatment of lymphoma. Radioactively labeled yttrium is available as well. It is a drug that is using rituximab as the backbone. So again, it is targeting CD20 and then linked to radioactive yttrium. It is given intravenously. It is not a good drug to use if there is heavy bone marrow involvement, as it can damage the healthy blood production. There is only limited trial data available. In the biggest trial, 16 patients were included only. But again, the response rates are very high. The 5-year overall survival in, again, a heavily pre-treated patient population was 72% at 5 years. I just want to briefly mention other treatments, including bone marrow transplant, CAR T-cell and immunotherapy. These are rarely used and currently only available on clinical trials. We will wait and see what happens to these very fascinating and new treatment options down the road. But currently, as I said, only available in clinical trials. What kind of complications should we be aware of? The most feared complication is a transformation to an aggressive subtype of lymphoma, so-called large cell lymphoma. About 15% of patients with nodal marginal zone lymphoma can be affected. If this event occurs, it is often associated with pronounced B symptoms, so fevers, weight loss, night sweats, and usually rapidly growing lymph nodes or tumors. At this point, a PET scan should be entertained because it can help to decide on an appropriate biopsy site. Large cell lymphomas are a life-threatening subtype, an aggressive subtype of lymphoma, and the treatment should then be aimed at the aggressive disease. Usually, it would treat the marginal zone lymphoma at the same time. The outcome from transformed disease varies. It depends on a patient. Are there comorbidities that would prevent him or her to undergo more intensified treatment? How many other previous treatments did this patient undergo, and so on? Another infection which is commonly seen is infections. White cells are usually part of the immune system of a healthy human being, and lymphoma is a cancer of the immune system. Treatment with chemotherapy leads to further immunosuppression. Because of this, we advise all our patients to undergo the yearly flu vaccine, receive the pneumonia vaccine, and consider obtaining the shingles vaccine as well. COVID-19 vaccine is safe in patients with lymphoma. It might be less effective, but nonetheless, we strongly encourage everyone to receive the COVID vaccine, and this would include a third booster dose in this patient population. Other things that I would like to mention is that this journey of marginal zone lymphoma should not be just between the patient and the oncologist, but should involve the primary care provider, so the family physician as well. The family provider continues to play a very, very important role in the patient's life, as the GP might be in a much better position to continue to monitor other health issues like high blood pressure, diabetes, and so on. Also, other cancer screening, breast cancer, pap smears, and so on, should be all done through the primary care provider. Once a patient underwent chemotherapy, he or she should undergo follow-up ongoing. This does not necessarily have to be the oncologist or hematologist, but can also be the primary care provider. This would entail a physical exam and some basic blood work once or twice a year. I'm not a big proponent of surveillance scans, as they can often lead to false positive results, cause a lot of anxiety and angst, and the amount of radiation is not negligible. So in conclusion, marginal zone lymphoma is a heterogeneous group of diseases. In general, it is slow growing and indolent, and the outcome is rather excellent. Limited stage disease can be treated in curative intent. Advanced stage disease is only treated if symptomatic, and there are multiple chemotherapy regimens available nowadays that are very effective and very well tolerated. Relapses can occur years or sometimes even decades after the initial therapy. Multiple treatment options are already available at this point, and there is a lot of research ongoing looking into targeted and chemo-free regimens. With this, I would like to conclude. I'm happy to answer additional questions in the upcoming live Q&A session. Thank you very much.
Thank you very much. That was an excellent presentation on marginal zone lymphomas. As you mentioned, MZL can be an umbrella term for common subtypes like you saw, such as nodal, splenic, MALT lymphomas, and each will have their different treatment approaches. So it is important to speak with your doctor about those different approaches and what the best steps are for you. We really appreciate your excellent overview of this lymphoma subtype, detailing the treatment options for patients in both frontline and relapsed refractory settings, and also highlighting some of the newer treatment options that might become available for Canadians. I would now like to direct our audience to attend the breakout session on non-Hodgkin lymphoma to have your questions answered live by a panel of hematologists and medical oncologists. Thank you very much.